Sudden cardiac death is defined as death presumed to be of cardiac cause that occurs within 1 hour of onset of cardiac symptoms if witnessed, or 24 hours of last being seen healthy and alive if unwitnessed. So sudden cardiac death is a dramatic event that does not recognize a single possible cause but can be attributed to a multitude of triggers and underlying syndromes with different pathophysiology that are often not fully understood. It is responsible for 10% of the global mortality and 50% of cardiovascular death. Estimated survival of less than 10% for out of hospital cardiac arrest. More than 90% of them being fit.
Out of hospital.
Out of hospital.
सडन कार्डियक डेथ की डेफिनेशन करते हैं.
Sudden cardiac death is defined as death presumed to be of a cardiac cause that occurs within 1 hour of onset of cardiac symptoms if witnessed, or 24 hours of last being seen healthy and alive if unwitnessed. And it is a dramatic event that does not recognize a single cause but can be attributed to a multitude of triggers and underlying syndromes which are not often fully understood. It is responsible for 10% of global mortality and 50% of cardiovascular death. An estimated survival of less than 10% out of hospital cardiac arrest, more than 90% of them being fatal.
This is US data. India might is not even more than 1%.
So basically, sudden cardiac death can be divided into two parts. That is, it can be an expression of an overt structural heart disease such as coronary artery disease, cardiomyopathy, myocarditis, and it can also be without any structural heart disease, that it can be an expression of a primary electric disease that can be long QT syndrome or short QT, Brugada, early repolarization and others. Despite the advancement of our knowledge and modern imaging methods, the ECG has been and continues to be considered one of the main screening methods that can provide useful information in assessing arrhythmic risk in different types of patients. So initially the ECG changes will be related to specific diseases and then non-specific ECG changes. So first is the epsilon waves. Epsilon wave is a small deflection, that is blip or a wiggle, which is buried in the end of the QRS complex, best seen in ST segment of V1 and V2, and they are usually present in lead V1 through V4. So it is a characteristic finding in the patients with ARVD, that is arrhythmogenic right ventricular dysplasia or arrhythmogenic right ventricular cardiomyopathy. So what is ARVD? ARVD is a genetically determined heart muscle disease in which the myocytes are replaced by the fat tissues. So there is producing islands of viable myocytes in the sea of fat. So this causes a delay in the excitation of some of the myocytes of the right ventricle, producing a small blip seen during the ST segment of the ECG. And the fibrofatty replacement of the right or the left ventricular myocardium causes ventricular arrhythmias and sudden cardiac death.
So, if it is delaying excitation in the right ventricle myocardium, why epsilon wave will come at the end of ST segment?
So because
Shouldn't it come little earlier?
because initially in the QRS deflection, the positive R wave is seen because mainly of the left ventricle, that is the wave of the left ventricle. And so it will be seen. Initially the Q wave is due to the septal depolarization and R wave is due to the left ventricular depolarization. So as you can see, there are different types. First is the wiggle wave in the first figure. As you can see, the small wiggle wave. It can be a small spike upwards also in the upward direction, or it can be a small spike in the downward direction also. And here there is a QRS in V1 is more than QRS in the lateral leads than V3, V4, V4. So these are the different presentations of epsilon wave. So this is a very small wave, so it cannot be clearly, but if it is predominantly seen in the right precordial leads, that is the V1, V2, V3, then we can think in the direction of ARVC. If it is present in almost all the leads, then we can consider it as an artifact. So other ECG changes in ARVC, first we saw is the epsilon wave, which is the most specific finding seen in 50% of the patients. Another finding seen in 85% of the patients is T wave inversions in V1, V2, V3. There is localized QRS widening in V1, V2, V3 and prolonged S wave upstroke. And the cause of sudden cardiac death in the patients with ARVC is mostly episode of ventricular tachycardia with the LVBB morphology, as the VT is originating from the RVOT. So as we can see all the changes, first of all we can see that there are small wiggle waves in V1, V2, V3 with T wave inversions. There is QRS prolongation in V1, V2, V3 and not in V4, V5, V6. So these are the ECG changes
So
which
feature wave almost bધી જ રીડમાં છે.
yes sir, it is
તો આર્ટિફેક્ટ નથી.
yes sir, but we can correlate it with other ECG findings of ARVC.
પણ બધી લીડમાં હોવું may not be a differentiating feature. I may be wrong, પણ આવું લાગે છે.
છેલ્લે સુઈ છે.
લીડ 1 to V6 સુધી બધામાં જ.
This is the revised task force criteria for diagnosis of ARVC. Basically, the important point here is that epsilon wave is considered to be a major criteria for diagnosing ARVC.
એક PGS છે ને સોફ્ટવેર એપ્લિકેશન આવે છે કે તમે એની અંદર નાખો ને તો તમારું જે આર્ટિફેક્ટ હોય ને બધા જતા રહે અને આર્ટિફેક્ટ વગરનો ECG મળે. આઈ થિંક એવી એક છે એપ્લિકેશન અને ફોનમાં છે તો એમાં નાખીને કદાચ આઈ ડોન્ટ નો આ તો જશે.
On echocardiography and cardiac MRI, ARVC shows RV dilatation, RV aneurysm, RV dysfunction, and free wall hypokinesia. So as you can see, there is RVOT which is dilated here, and RV dilatation is seen on the 4-chamber view also. Management. This is a disease in which sympathetic stimulation accelerates progression of the disease. So beta blocker is the drug of choice. And secondly, avoiding competitive sports is even a stronger recommendation in ARVC than in hypertrophic cardiomyopathy. ICD placement in patients with increased risk of sudden cardiac death, that is VT, VF, or episodes of NSVT or syncope. Radiofrequency ablation has limited utility due to the diffuse abnormal disease which is present in the eye. So this was the first ECG finding.
ARVC diagnose થાય પણ VT, VF કે NSVT નો એપિસોડ ના થયો then will you subject for ICD?
No sir, then we have to give
Wait
suggestion.
till VT to occur. He might die.
So there are various risk factor prognostication scores for it, and based on which we have
So
to
કોઈ
decide
event
whether
વગર ICD નો class of recommendation ને level of evidence શું છે?
so if there is an episode of VT, VF or NSVT, that is class 1, and
એના વગર
and apart from that there is a risk score in which it is divided into high risk and intermediate, where the indication is class 2A and class 2B, and class 3 recommendation if there is no risk of any of the following. In that way it is divided.
how will you risk stratify if there is no event?
Then it is class 3 indications.
It is class 3.
Yes. Next ECG pattern is Brugada pattern. So Brugada pattern, there are 3 types of Brugada pattern. First, type 1 is the most specific and most important, where there is J point elevation more than 2 mm with a code type of ST segment elevation, which is gradually descending downwards with a negative T wave. This is type 1. Type 2 is a saddleback or a biphasic type of T wave configuration with a terminal part of ST segment elevated more than 1 mm. And type 3 is again a positive or a saddleback type, but here the terminal part of ST segment is elevated less than 1 mm. So these are 3 types of Brugada pattern which are seen on the ECG.
Which leads are the V1 to
1, 2, 3.
So type 1 Brugada ECG abnormality must be associated with one of the following clinical criteria to make the diagnosis of Brugada syndrome. That is documented VF or polymorphic VT, family history of sudden cardiac death at less than 45 years of age, code type ECG in family members, history of syncope, a history of nocturnal agonal respiration. basic mechanism include loss of function of SCN5AG leading to a sodium channelopathy and leading to diminished current in the epicardium of RBOT. There is polymorphic VT episodes which occur during sleep or rest which leads to sudden cardiac death. And presence of spontaneous type 1 Brugada pattern have higher risk of serious adverse events. So only proven therapy is an ICD or quinidine or amiodarone have been proposed as an alternative in settings where ICDs are unavailable. Conditions where we can see ECG changes similar to Brugada pattern is first is lead misplacement if the V1, V2 leads are placed too high. Second is hyperkalemia, acute anterior wall MI, Prince metal angina, and other is drug induced which can be caused by many antiarrhythmic drugs like flecainide, propafenone, procainamide, and tricyclic antidepressant overdose. Third ECG finding is delta wave. Delta wave is seen classically in Wolff-Parkinson-White syndrome. The ECG changes of the Wolff-Parkinson-White syndrome includes first is short PR interval less than 120 millisecond. Second is a slurring slow rise of the initial portion of the QRS, which is actually called as the delta wave. And third is the QRS prolongation of more than 110 milliseconds. Now why these changes occur is there is an accessory pathway, atrioventricular pathway, which is present in patients of WPW syndrome. Now initially normally there is an SA node, in the AV node there is AV conduction delay, but here the impulse passed from the right atrium towards the ventricle via the accessory pathway, because of which there is a short PR interval. After this, initially there is muscle to muscle conduction of the impulse till it reaches the conduction pathway. So because of which there is a delta wave, slow uprise of the QRS, and overall the QRS has prolonged due to the delta wave. So these are the three ECG changes seen in WPW. There are two types of tachyarrhythmias seen in WPW syndrome. One is the AVRT. If there is a formation of the re-entry circuit involving the accessory pathway, then AVRT is seen. The arrhythmia causing the sudden cardiac death is pre-excited atrial fibrillation. So as the accessory pathway lack the decremental conduction properties of the AV node, sudden cardiac death is in WPW is most often related to occurrence of atrial fibrillation. So now all the atrial fibrillation impulses will pass toward via the accessory pathway into the ventricle, leading to VF and sudden cardiac death. So whenever we see a patient with these ECG findings, we first go for exercise stress test, and if there is persistent presence of the pre-excitation on ECG even after exercise stress test, then it further requires EP study and ablation of the accessory pathway. Fourth ECG change is the QT interval. QT interval basically represents the time between the ventricular depolarization onset and the repolarization offset. And both short and long QT intervals can cause a variety of life-threatening ventricular arrhythmias. The accepted normal range of corrected QT is 350 to 460, where the general cutoff is taken as 440 milliseconds. Basically, the hallmark arrhythmia, whenever the QT is prolonged, and if there is any ectopic or a VPC on QT, on the T wave, which is called as the R1T phenomenon. So if there is an R1T VPC in the background of QT prolongation, then it causes torsade de pointis, which is polymorphic VT, which is generally the cause of sudden cardiac death in prolonged QT interval. So based on the QT interval, first is the long QT syndrome, which is the most common channelopathy, estimated to occur in approximately 1 in 2500 people, putting them at risk of torsades and sudden cardiac death. So these are different variants of long QT. Three common types are: first is type 1 long QT, where the T wave has a broad base. In long QT type 2, there is an additional hump or notch on the T wave with a low amplitude T wave. And in type 3, the T wave occurs late and a long ST segment is present with a narrow base T wave. Various subtypes of long QT syndromes are encoded by different genes and are associated with different triggers, like swimming in case of LQT1, loud noise or alarm in LQT2, and sleeping in LQT3. There is a Schwartz scoring which is used to diagnose LQT. Basically, short scoring is used in patients whether to decide whether to go for genetic testing or not for long QT syndrome. And a score of more than 3 suggests high probability of long QT syndrome. In long QT syndrome, the highest risk category corresponds to a QT interval of more than 500 milliseconds with an annual risk of adverse events of about 2% and an absolute risk 2 to 3 times higher than patients with an interval of less than 500 milliseconds. Management includes beta blockers, avoidance of triggers, and ICD placement if safe cardiac arrest, if beta blocker is intolerable, if QT is more than 500, or if T-wave alternance is present in these patients. Next syndrome based on the QT interval is the short QT syndrome. It is a rare syndrome but most severe channelopathy. It is diagnosed in presence if the QT is less than 330 milliseconds or with a QTC less than 360 milliseconds with any of the following, where first is a documented gene mutation, family history of short QT syndrome, family history of sudden cardiac death at age less than 40, or prior VTVF episode that is otherwise unexplained. So as you can see that there is short QT interval. So these were the ECG changes related to specific diseases. Now these are non-specific ECG changes which are predictors of sudden cardiac death. One is QRS fragmentation. So in absence of any bundle branch block, if the QRS duration less than 120 milliseconds, evidence of an additional R dash or an RS-R dash pattern, or if there is a presence of notching of R wave or nadir of S wave in two contiguous leads, then it enables us to identify narrow fragmented QRS. And if there is a bundle branch block present, then two notches at the level of R or S wave in two contiguous leads makes the diagnosis of a fragmented QRS. So fragmented QRS is expression of slow conduction or disk array of electrical stimulus through the myocardium, and it has been related to myocardial scarring, ventricular aneurysm, or reduction of the left ventricular strain. So as you can see in this, these three are RS-R dash patterns with an arrow QRS, and here there is a notched S wave, notched R wave, or a completely fragmented QRS segment. So these are all varieties of fragmented QRS. In this there is an FQRS scoring system which includes duration, amplitude, notching in 10 out of 12 leads, excluding the lead 3 and area. So higher the score, higher are the chances of sudden cardiac death. It has also been investigated as a prognostic marker of sudden cardiac death in numerous diseases such as ischemic cardiomyopathy, dilated cardiomyopathy, and ARVC. Various studies have demonstrated that fragmented QRS was associated with approximately twofold risk of sudden cardiac death in patients with ischemic cardiomyopathy and even in non-ischemic cardiomyopathy. Main limitation is that it is frequently observed in apparently healthy individuals. Next predictor is QRS duration.
What do you do? If you find this electric finding, do you give anything?
Sir, as such, for basic QRS fragmentation, as it is a result of ischemic cardiomyopathy or dilated cardiomyopathy,
It
is just a prognostic marker, sir, as such.
If you see you don't do anything.
Yes. For QRS fragmentation, sir, there are no further recommendations.
Basic disease.
It is just because of the cause.
Please underline this.
Next is QRS duration. QRS duration expresses the delayed depolarization and impulse propagation through the myocardium. Normal QRS duration is 70 to 100 milliseconds, and duration of 110 is sometimes observed in healthy individuals. Even a 10 millisecond increase in QRS duration entailed a higher risk of sudden cardiac death. 2.5 times higher sudden cardiac death risk when QRS more than 110 milliseconds compared to QRS less than 95 milliseconds. So QRS duration is one more marker or predictor of sudden cardiac death. Next is early repolarization pattern. So early repolarization is defined as elevation of the J point. J point is a junction between the QRS complex and the ST segment. So the J point is elevated more than 1 millimeter in two contiguous inferior and lateral leads. So depending on different morphologies of ST segment following the J point, we can divide early repolarization into benign and malignant. So the malignant form is represented when the ST is flat or downsloping, and benign is characterized by an upsloping ST segment. So as we can see that in this the J point is elevated, and if the ST segment is flat or if the ST segment is downsloping, then we can consider it malignant early repolarization. And benign early repolarization is when the ST segment is directed upward with the J point elevation. So classically, early repolarization has been considered a normal variant, but literature has described a potential role for this finding as a prognosticator of risk of ventricular arrhythmias. Studies have shown that there is increased incidence of VF in patients with early repolarization compared to healthy subjects. Studies have also shown that there is high prevalence of ER pattern in the first degree relatives of patients with sudden cardiac arrest. And presence of early repolarization increases the risk of ventricular fibrillation within 48 hours of acute myocardial infarction. Next ECG change is T-wave alternance. T-wave alternance is beat-to-beat variation of T-wave on the same beat. That is, variability can be seen in polarity, shape or morphology. And presence of T-wave alternance increases the risk of ventricular arrhythmias. T-wave alternance could be a frequent and non-definitive pathologic finding with elevated heart rate, but it is always pathological at a heart rate less than 110 beats per minute. In patients with recent MI, evidence of T-wave alternance is a strong predictor of arrhythmic events. So as you can see in this ECG, there is different polarity as well as the morphology of T waves changes with each beat in a single lead, which is called as T-wave alternance, and it is also a predictor of ventricular arrhythmias. Next ECG predictor is T peak to T end. So T peak to T end is that the interval from the peak of the T wave to the end of the T wave. So this part is the T peak to T end interval, and it was shown to be associated with dispersion of repolarization across the 3 layers of the heart wall, and consequently lengthening of this interval could predispose to occurrence of ventricular arrhythmia. So as we can see that if there is a prolongation of the T peak to T end interval, there are more chances of a ectopic falling of the T leading to ROT phenomenon and ultimately leading to ventricular arrhythmias. And amplification of this interval above 100 millisecond is pathological. Longer T peak to T end interval has been shown to predict ventricular tachycardias, sudden death or both in many populations with diverse characteristics including long QT, MI and Brugada. Similarly, in patients with STEMI undergoing primary PCI, patients with pre-PCI TP interval above 100 millisecond were associated with increased mortality. And in patients with LV dysfunction, the TP interval with a mean value of 107 millisecond was associated with an increased risk of VT, VF and even mortality. This is the last ECG predictor, that is beat-to-beat variability, which refers to fluctuation in the time interval between consecutive heartbeats, and it measures as the variation in the RR interval. Heart rate variability has been shown to be an index of parasympathetic function, and lower variability has been linked to ventricular arrhythmias and mortality. For example, in post-MI patients with low variability, so variability is indicated by standard deviation of all the normal RR interval. So if it is less than 50 milliseconds, so that is said to be low variability. So it had a significant higher 1-year mortality compared to patients with the standard deviation of more than 50 milliseconds. So basically it is just an index of the parasympathetic function, and it lower the beat to beat variability, higher are the chances of mortality and ventricular arrhythmias. So these are basically all the ECG, some of the ECG predictors which can help us to predict and prognosticate sudden cardiac death.
So
Without this,
treatment
Treatment.
beat to beat range.
So beat to beat variability is generally seen in generally detected on Holter monitoring. It is not seen on generally not seen on the 12-lead ECG. So management, sir, I was good at beat to beat variability management.
એનું illustration કેમ નથી મૂક્યું?
Also because generally
હશે ક્યાંક ને ક્યાંક લિટરેચરમાં.
So conclusion, the ECG provides both diagnostic and prognostic information, and it is a powerful diagnostic tool to prevent sudden cardiac death. Early identification of high risk individuals allow timely intervention to prevent sudden